So I wasn't actually going to film any of this, but then I just thought, well, maybe it might be interesting to somebody, may even be helpful to another person, and if that's ever the case, then it's probably worth doing the what probably end up being a series of videos. This is going to be about partial knee replacement, which I am unfortunately about to have done, and it's probably going to be an 18-month adventure. I was quite active until COVID hit, playing golf 2 or 3 times a week. Slight aches and pains in my knee, as you expect at, what was I, 58, 59. Not really a cause for concern, but after the first year or 2 of COVID, my right knee started to get really painful. Talking on the inside, the medial side of the joint, and it was painful enough to actually try and get an appointment with a surgeon for a chat. Now, I'm really lucky. We have private health cover through Debbie's company, so we were able to literally phone up and get an appointment within a day or 2. And just a little tip here for people that don't have the luxury of private health cover: you can get to see a consultant pretty quickly, within days very often, and you can actually pay to do that. If you pay £150, £200 to see the consultant, even though you're an NHS patient, they can very often sneak you in earlier on their NHS list if you have gone and seen them privately. You'll need a referral. We can't ever, I haven't seen my GP in as many years as I can remember, so we use, again, fortunately, it's the private health cover with Aviva includes an over the phone video conversation with a GP. So again, you can pay for that. It's about £50-60. So if you're struggling with anything and you just can't, we can't even get through on the phone to the GP, it's just a joke. They've introduced a new system just, I think, this week, where you do everything online. Avena, something like that. You go onto a website and it's open between 6:30 and 12, I think, for you to try and make appointments online. Again, I'm not wasting my time with it. We have registered with it, but I doubt it's going to make any difference. Anyway, the point I'm saying is, if you're struggling and you're in pain with something, you can't wait for the NHS, pay for a doctor's appointment, online, whatever it is, and then go and pay privately to see the consultant. As I say, that can often get you further along the NHS list if you do need surgery of some description. So I saw the surgeon, and they did some x-rays, and it was quite clear that both knees are quite badly worn on the inner side, the inner compartment. And initially we tried steroid and lubricating gel injections, and they worked for about 2 months. It pretty much took the pain away completely. Now, I hadn't noticed, but over the years the range of movement of my knees, flexion, has become less. I certainly couldn't kneel on my shins and go all the way flat like I used to do when I was a kid or a lot younger. And I think that sort of thing just sort of sneaks up on you. You can't do that, so you realise that and just stop doing it, and then don't ever think about it again. So obviously there'd been issues, for a long time. So yeah, the gel steroid injections, the health cover would pay only once for that. I did have one in each knee, and as I say, about 2 months relief, and I've pretty much gone on with it for the past 2 years. I've been back to see the consultant once before. I have tried painkillers, they don't work. Elasticated cuff around the knees, that doesn't work. Icing, that doesn't work. Diclofenac or ibuprofen gel around the area, that doesn't work. Nothing touches this particular pain. And anyone who has osteoarthritis in any of their joints will know what I'm talking about when I say if I bend this knee the wrong way, the pain is instant and 100%. It is a searing, burning pain that makes you gasp out loud. It's a bit embarrassing in Sainsbury's or wherever, and you just catch your foot awkwardly on, scuff it the wrong way, and you're gasping in pain because it doesn't look like there's anything wrong with you, but it is a particularly horrible pain. Now, day to day, if it's aching and it hurts a bit, you just get on with it. And hope that you don't scuff your foot, the wrong way. And when I'm talking about scuffing my foot, so if I bend it that way, so say I kick that's not a problem. I can go out into the garden and I can kick the apples off the lawn into the flower beds, like that. But if I kick anything that way or scuff my foot, get it dragging that way, that is absolute agony, and very, very unpleasant pain. Now, really, the final straw for me was I sleep on my right hand side, and I now can't lie in any of the positions that I sleep in without being in extreme pain from this left knee. The pain from the right knee subsided, actually. I was talking about my right knee, wasn't I? And that suddenly just sort of stopped. I still get a little twinge in it from time to time, and the wear is very similar to the left knee, but for some reason all of the pain now is concentrated on this inner left knee joint. So I can't sleep. There's no position I can sleep in without being in extreme pain. The only way I can get any sleep is if I lie on my right hand side. If that's the edge of the mattress, I have to stick my leg out, rest my knee joint on the edge of the mattress, and my whole leg has to hang there in midair, and somehow that takes the pressure off of the painful joint, and it's fine, but that's hardly convenient, hanging your whole leg out of the bed. Of course, the main problem is when you're asleep and you move in the bed. Oh, Jesus, I've actually jumped up in the bed with the pain as I've been asleep, and I've rolled over. I've done something like that. Absolute worst pain that you can get. And I've had kidney stones, and I've had a really bad hiatal hernia as well, and all of those pains are particularly unpleasant. It's perhaps something you get used to if it comes on gradually. I can deal with kidney stones if I get them now until they've passed without too much of a problem. It's not pleasant, but it really, really hurts, but I've dealt with them. But this comes on so suddenly, you just cannot deal with it or comprehend how bad that is unless you've tried it. Anyway, went back to the consultant a couple of weeks ago, and I said, look, I don't think I can deal with this pain much longer. Something else that realised that's really changed what I do. A friend of ours, Kim, has a new puppy. We went over to see the puppy, and you know how you run around the garden, you stop and start and play with the puppy. I couldn't do it. It was so painful. I wasn't actually able to do that properly. And then I realised just how much this is affecting me. But I just stopped doing things that cause the pain. And I don't think you realise, and it can sneak up gradually until you're actually not doing... Oh, I certainly can't play golf, but that's more to do with the arthritis in the thumb bases here, and that's another story. Anyway, the surgeon said, look, he took some more x-rays, we had another look. I've got some MRI scans done as well. I think that was, oh gosh, when was that? April maybe? I'll have a look, I'll show you the scan in a minute. And he said, look, you're a candidate for a partial knee replacement. Obviously this is a much better choice than a total knee replacement. It's slightly less serious surgery, and it is a slightly quicker recovery time. So that is what we are going to go for. And I'm holding this book up like it's important, but one of the things I think a lot of people do not realise how serious a total knee replacement or partial knee replacement surgery is. It is a widespread operation. I think the figures were something like 70,000 are done every year in the private sector. I've no idea how many are done in public, the NHS sector. Probably an awful lot more. So it's been around an awful long time. They have refined things hugely. Robotics have really moved in and taken over to get things as accurate as possible, because all of the different angles of where the implants are, it's all critical to the outcome. So yes, I've literally had just a couple of weeks to prepare for the surgery, which is on Monday. This what am I doing? It's Friday now, so I'm filming this Friday afternoon. Really, you need to prepare yourself for some months if you can before surgery. This particular book, I think it's American. Most of these things seem to be American, but it is all about prehab workouts, trying to lose some weight, eat healthily. We're talking 1 to 3 months before surgery. You should be doing these exercises if you can, just to strengthen everything as much as possible. And if you think it's nothing, imagine you can't move your left leg very much. Just straighten it out, and now try and lift yourself out of a chair on one leg. You've got to be pretty fit to lift yourself up on one leg, or one leg and one arm. It's hard work. So the fitter you are before surgery, the better. I quite like this book from Amazon because it really covers everything. Obviously it doesn't remove what your surgeon is saying, your physiotherapist is saying, but there are a lot of exercises here, and they talk about one day after, this is before surgery, and then they go on to the day of surgery, after surgery, and you've got all of the exercises. You've got little tick boxes that you tick on every day as you work through the exercises, but obviously you need to do whatever your physiotherapist is telling you to do. This is not a walk in the park. In fact, one of the first meetings I was asked to go to was a group physiotherapy session with a very good physiotherapist over at Woodlands Wood Hospital. It's part of the Ramsey group, same as the Woodlands, where the op will be carried out. I sat at the back, deliberately out of the way, and there were probably another 12 patients in there, and all of them, strangely enough, were having total knee replacements. And obviously partial is much better if you can get away with it. Every time apparently it is a better option, because if I have any problems with this in the future, they can resort to a total knee replacement. So yeah, in my case it's obviously the right option. Anyway, as the physiotherapist was running through the slideshow, the first thing it started off with was a sentence saying, "This is major surgery," and I think that sort of made most people stop and think. This is not just a simple surgery. The knee joint is the most complex joint in your body, and you're going to have a cut from a few inches above your knee to a few inches below it. They are going to be levering your kneecap out, all of the muscles, tendons and everything else out of the way to get to the bone, and then they'll be cutting lumps of bone out from all of the bone, top and bottom bones, and then drilling and cutting, hammering in artificial things, and then pulling everything back over and sealing it all up. So it really is major surgery. It is going to take a long time to get over it. The very final little bits of swelling might not disappear until 18 months after the surgery. So be warned. I think a lot of these people in the meeting with me, I think, were reconsidering their options after they'd been through the full talk about how it's going to be, what they're going to need to do. It's going to be hell, especially the first 6 weeks. Scar tissue is laid down over the first 6 weeks, and if you do not do all of the correct exercises regularly, your knee is not going to achieve the extension and flexion that you must have. So you've got 6 weeks, that's it. Once that scar tissue is laid down and you don't break it up, then I think the outcome is not going to be optimal, shall we say. So you've got to do every single exercise. So yeah, certainly I would advise getting a book. Now, I've watched every video, I've watched every operation, I've looked at the lectures, everything that's available on YouTube and elsewhere, even down to watching spinal blocks being administered, because even that's not a straightforward thing. It's very, very complicated. All sorts of things can go wrong, although it's very rare. It can go wrong. The most important thing is DVT and PEs. So a clot in your calf, pulmonary embolisms, that type of thing. This sort of thing can kill you. So you've got to be very aware of that sort of thing. They cover all of this. I'm going to go through some of the things that I've been given. Obviously, they are going to be treating you with painkillers, antibiotics, blood thinners, all of this stuff. Orthopedic surgery is particularly known for DVTs, I think. So, yeah. Currently, I have the book. I have some big elastic band type things where you hold it. Like they use in the gym, great big bands that you put around your foot and you pull and you bend your knee and all that sort of thing. I have a gym step, adjustable height step, so you can practice stepping up, stepping down, stepping up and then stepping over and down. I have a cooling and compressing machine here, and I think I'm going to review this separately on another video, because this you must ice your knee frequently and for 20 minutes at a time. Cooling and your knee, reducing the swelling and pain is absolutely critical. This machine is 170 quid, and I think it's one of the biggest rip-offs I've ever come across in my life. But we'll look at it on a separate video. But if it works and it does the job better than a ice gel cuff, which I've got 2 of, then fair enough. You can't put a price on a quicker recovery or a less painful recovery. But we'll see. I'm going to reserve my judgment on that one. We're lucky we've also got an elliptical cross trainer, so that is where the pedals just like big paddles that you put your feet on, and if you can't bend your knee very much, you can actually just rock these things backwards and forwards and get a very small amount of knee bend, but it is no impact, so it's perfect for, I try and do 15 minutes a day at the moment. I'm not now, because really you need to be well rested and fed before the surgery. So exercise before, diet before, get fit before, and stay hydrated. Absolutely crucial. I mean, day to day you should stay hydrated. Most of us are severely dehydrated if you look at the research. So I'm drinking at least 5 pints a day, plus all the normal teas and bits and pieces. I actually feel better for it as well. It's very easy not to drink, but it's really not very healthy. Let me show you the troublesome knee. spin this camera around. So that is the MRI of my left knee. So femur, tibia, and that is the gap, and this is where the cartilage is. Now there's a nice even gap. This one, I mean, to me that looks pretty good, but apparently it isn't. But you'll often see videos where there's virtually no gap here, and this side looks quite good. Well, you know, that is bone on bone, and it's agonising. But everybody seems to be very different. I mean, I don't think there's much wear there, but it's agony. Other people apparently can have, you know, virtually no gap on one side, and they're actually walking around without any any real problems. And yeah, this one goes through, I think that is the kneecap, and they're doing 3mm sections going into the knee. That's how that is done, and there's the joint, and then you go through it and out the back. I think that's what we're looking at here. I've got a few bony little growths apparently, which I think they will cut off whilst they're in there, but they're basically going to, you know, take off a bit here, a bit there, and put some inserts in and seal it all up again. So that's what's going to be going on, and it sounds quite straightforward, but yeah, we'll see. Now, there is an awful lot of stuff you've got to go through, and I'm just going to go through that with you. It is all about infection control these days. You do not want an infected joint or anything like that, so everything they do is discussing that. So I have had blood tests, MRSA smear, x-rays, MRI scans in preparation for this. I have had the group 1 hour physiotherapy meeting. Monday I had a set of blood tests done, and that's when the MRSA swab was done. Tuesday we went back for no, hang on, yeah, so that was Monday and Tuesday. Tomorrow morning I have to go back for final blood tests, just to make sure that everything is still okay to proceed. It's only then 2 days before the operation, so I think that's about as late as they can leave the last blood tests. Now, we've been given a pack when we were over there on Tuesday having the blood tests. They are going to give you some, I don't know how you pronounce it, Oxinium, I don't know. It's pretty much like Hippie Scrub. I imagine most people have heard of Hippie Scrub. They are going to want you to wash and shower solely in this every single day. Hair and body, you've got to shower in this. It's got to stay on everywhere for at least 1 minute, and you repeat that every day for 5 days. Also, you are going to get a nasal gel, and this is going up the snout each side, a little blob of gel on one finger, then you just pinch your nose and just rub it all in and leave that there. That helps to kill off the colonies of nasties that are up your nose. So that's all infection control. They give you cards on how to apply everything, and there on the back then is a little box for each day that you can tick to make sure that you have done it. We're on day 3 today, so that again is quite critical. The first day you have to change the bedclothes, and you have to use fresh towels every single day, and you know, use this properly for the correct length of time. Critical. It's just so important. We have a form about just reducing your risk of developing a blood clot. It tells you all about them, what to do if you suspect anything like that. There's another form all about spinal anaesthetics, and that is very interesting if you're interested in this sort of thing like I am. General's far more risk with a general anaesthetic. Spinal, I mean, I like the idea of a general. You just go into the room, they inject you with whatever and you fall asleep. Spinal, you're going to be sat there, someone's going to put a guide needle in after numbing the area, and then the very tiny needle goes in and they inject the numbing medicine, and then your legs go numb, and no, it just sounds horrible. I'm not going to be very happy with that. Apparently when it starts to come round, it's kind of like going to the dentist and having an injection, numbing injection, that tingling you get, and you're sort of massaging your jaw to bring it back. Sometimes you get the feeling back in your legs first, but you can't move them. Sometimes you can move them but can't feel them. It just sounds absolutely horrible. So really not looking forward to that. Now in my case, I've got to go in at 7:15 in the morning. I hate early mornings. I do not operate well in early mornings. I'm much more a later morning, evening person. Much happier working in the evening and at night. But that's the luck of the draw. So what they also give you is, I've never heard of it before, but it is a carbohydrate preload. So I guess they do not want your blood sugar levels dropping quickly at any point. So we have one of these in the evening, sort of 5-6 with dinner, one supper time, and one during the actually it might have been lunchtime, dinner time, and first thing in the morning, sort of 6, no later than 6, and that's a sachet, 3 sachets that you mix with water, and it pretty much is 95% carbohydrate. So yeah, we've got to take that. There is a guide on taking all of that, and then we've got all sorts of booklets on avoiding trips and slips and falls in the hospital. Something else I'm really looking forward to is the constipation. They are going to give you opioid-based painkillers, even giving you liquid morphine if required. Really not looking forward to any of that. And of course they are well known for giving you constipation. In fact, you have to take lactulose or similar thing for constipation. So that's going to be a bundle of laughs. Hand hygiene, yeah, I mean, we're all aware of that since COVID, I would think. And it's also talking about the hospital staff. Don't feel bad about asking them to wash their hands if you don't think they did as they come to you from another patient. Managing your pain after the operation, and we've got a pain scale, what tablets to take. So if your pain's very low, that's green, so it's paracetamol and ibuprofen, naproxen, that type of thing. If it's in the yellow, medium, then they're suggesting codeine, dihydrochloric codeine, tramadol, that sort of thing. And if its pain is severe, between 7 and 10 in the red, they are talking about liquid morphine. Oh God. Obviously highly addictive. It's going to make you drowsy. I actually need to carry on working in the workshop somehow. Everybody else would be getting a 3-month sick note, but I've somehow got to be able to drag myself out into the workshop and do at least one repair, then stand up and exercise. It's going to be an absolute nightmare. This one is all about the knee surgery, before, during the stay, how it's going to work, how your bladder probably won't work properly after the painkiller, spinal block, cold therapy, x-rays before you go out, dressings, diet, wound care. I've got some protein shakes, protein bars. You've got to have protein, good level of protein to heal properly. So it is going to be interesting. We have got here anyway a we've got wheelchairs, walkers, walking frames, we have frames around the toilet, because unless you're super fit, you're not going to be able to stand up on one leg. I certainly can't do that. I never could, even when I was at my fittest when I was about 20. So we've got all of these aids in place. After the surgery, I'm talking immediately after the surgery, they're going to have you up, walking. You've got to be able to go up and down stairs. You've got to be able to use the frame. Eventually all this is to proceed to a walking stick, and as soon as you can walk limp free, you'll be doing that, but that's not going to be for some months. Apparently it's very important to use these aids and don't go limping around unaided. It is really bad for all of the other joints. So yeah, use your walker until you can walk almost normally. I think you've got to stick with these aids. Tips for going up and down stairs, travelling by car, exercise program, all of the exercises which are pretty much repeated in my total knee replacement book. Raising the leg. I've got a wedge. I'm lucky we've got a bedroom downstairs and my normal bedroom upstairs. Downstairs will be for afternoon rests, and we've got a wedge where I can get my leg above my heart, and that will help drain the swelling from the leg. So there's a whole shed load of things to remember to do. Now everyone's going to recover differently. Some people will be running around the room within a week, others it might take 3 months. So another tip I think there is, it's your journey. Don't be getting information from other people that have had the surgery, because their experience is going to be completely different to yours. So that's it really. This is the start of an 18 months journey. Not looking forward to it, but how I look at it is it's not going to get any better. The joint pain is only going to get worse as the remaining cartilage is damaged. It's making me walk awkwardly, and that puts other strain on other joints and that sort of thing. We have the private health cover in place currently. Debbie's not going to be working forever. I will be. No pension plans for me. But we have it in place now. So is there any point in waiting a few more years? Because if we lose the private health cover, I might just be then on a NHS waiting list, and it might be years. You don't know, do you, for sure? The surgeon is happy to do it. That's another thing. He didn't want to do it till I was 65 ideally, because really they don't want to do it a second time. So when I asked why 65, he said, well, the likelihood is you'll be dead before you've worn the partial knee joint out. So it's fair enough, I guess. What else? Yeah, and the pain is just horrible. If you can't sleep, it affects absolutely everything. I can't do. I'm lucky I can still kneel down, because when I kneel, I'm actually on the other part of my knee. So unless I do something stupid and rock over onto the worn knee, I can actually kneel without any any problems at the time. Yes, it hurts and aches later, but at the time I can actually kneel down, and that is quite a useful thing to have. Once you've had a total knee replacement, I believe that you can't kneel down on it again. So I certainly would not want to go down that route. So that's it really. If anyone's had a partial or total knee replacement, let me know. I'm going to do a film about this cooling cuff, because what is it with medical stuff that's so bloody expensive? And if it was normal from Amazon, it'd be about 20 quid, not 170. If it improves recovery time, it's worth every penny, I suppose. Tricky one. And of course you can't send it back once you've put any water inside it. So you can't put water in it and test it and think, oh God, that is just terrible. You've got to determine that now, and based on the feedback, a number of people are very happy with it and say it was responsible for a faster recovery time, which is what we all want. So we'll do that, and I'll do updates as we go along, I think, really. I've got the last repairs, GHD repairs, coming in Saturday, and then after that, well, they'll still be coming in, but I just don't know how I'm going to get out here and do them. I have moved things around in the workshop, so I've cleared that, so that's where I work, and I can actually put my leg under there, and I can straighten it out completely, or bend it if I can actually bend it. So we can get around all of the rooms and into the workshop with the frame. I've done as much as possible there. I've done as much work as I can in the garden and everything else. So we've just got to go for it, I think, now. So yeah, next video will probably be sometime Monday. Might film from the room on my phone, and after the operation we'll just perhaps have a chat on the phone's video, and then I'll maybe upload those onto YouTube. But I think I might be busy on the Monday. They're going to have you out of bed pretty quick, doing exercises, and then there'll be more tests, all sorts of things, x-rays. I think it's be a busy day. I'm in there overnight. The Americans are very keen on getting people as day case, but I think there might be a bit of a rush, to be fair. There's a lot of people involved. You've got to see the surgeon after the op, you've got to see the physiotherapist, you've got to go for x-rays, plus you're going to feel pretty bloody knackered and probably in quite a lot of pain. So somebody looking after you over that first night is probably the way to go, I think. So anyway, I'll upload this today probably, and we'll keep you updated. Oh, I've got another video on a DJI camera. I'm sick to death of the focus of this not working properly as I move things around. That's another video which I'll do over the weekend, hopefully. So anyway, thanks for listening to my drivel as always, and I'll catch you later.